Hello, everybody. Good afternoon. I hope you all had a nice lunch, and I want to welcome you back to the Overdose Prevention, Harm Reduction, and Treatment series. Right now, I'm excited to get the scoop on Bupe from Dr. Grant Comstock. Dr. Comstock is a physician in emergency medicine and medical toxicology. He completed his residency and fellowship at Denver Health in Denver, Colorado, and is currently practicing at the Medical College of Wisconsin in Milwaukee, Wisconsin. Specifically, his interests include drugs of abuse, harm reduction, and novel antidotes. Feel free to ask questions through the chat, and I will pass them along to Dr. Comstock, who will answer them at the end of the presentation as time allows. So thank you, Dr. Comstock, for generously giving your time today to help us understand the scoop on Bupe. And without further ado, Dr. Comstock, please take it away.
Awesome. Thanks, Justin. So good afternoon, everybody. Like Justin said, my name is Grant Comstock. I'm an ER doc here in Milwaukee, Wisconsin. I'm excited to be able to join y'all today. Let me share my screen. And as Justin mentioned, give you guys the scoop on Bupe. So a couple of goals for the talk today. We'll talk about some basic buprenorphine pharmacology, as well as some really relevant clinical outcomes when it comes to the use of buprenorphine for the treatment of opioid use disorder. We'll discuss briefly, at least, some recent regulatory updates, and then spend a little bit more time talking about some concepts, or the concept, I guess, of buprenorphine precipitated withdrawal and why we're talking about it so much now in the context of the fentanyl epidemic. I have no disclosures, but I will just make the quick aside that if I have a slip of the tongue and use any brand names, it is not an endorsement of any particular product. So with some basic pharmacology to begin, buprenorphine has two really key pharmacologic parameters that make it an ideal candidate for the treatment of opioid use disorder. So it is an opioid, it's semi-synthetic. It, like the other opioids, will bind the mu-opioid receptor and cause your typical opioid-related symptoms and features. So you'll get analgesia, you'll have some degree of pupillary constriction, maybe a little bit of constipation. In larger doses, maybe a bit of CNS depression, like a bit of somnolence. But the good news is with buprenorphine, as you continue to dose it higher and higher and higher, those more negative outcomes are actually quite limited. And that's because it's a partial agonist of the mu-opioid receptor, meaning it'll bind it a ton, but when it binds it, it doesn't turn it on to that 100% max go kind of level. It'll turn it on, half or partial way. And so more and more of it can bind, you can keep administering it, but you won't get just this infinite amount of these negative or untoward features like CNS depression or kind of a sedation. And you won't find that same degree of respiratory depression. It makes it a much safer candidate than the rest of the opioids that are available out there, and a good candidate when you talk about things like treatment of opioid use disorder. The other really key feature of buprenorphine when it comes to the treatment of OUD is the way that it binds the receptor. So I think an important thing to kind of split out in our minds is that binding a receptor in and of itself does not mean turning on the receptor. You think about things like naloxone. Well, naloxone binds that receptor, but it turns it off. It's an antagonist. Fentanyl will bind the receptor and turn it really, really on. And we have a good sense of that in how potent fentanyl is. So potency, which is how much it turns on that receptor at a certain dose, versus binding affinity are very different things. So buprenorphine, yeah, it has some good clinical impact at lower doses, but again, it's got that ceiling threshold. The other thing, though, is that when it binds a receptor, it binds it really tight. And so this is a little bit, I think, to look at this graph, it's a little bit inverse. A smaller bar equals higher or more avid binding. Buprenorphine is on the far left of this graph, meaning it is the most avid binding opioid out there for the mu-opioid receptor. The good feature for that is that, let's say you're taking buprenorphine either orally or you've had an IM or sub-Q injection, and then you have a relapse and you use some fentanyl or morphine or some oxycodone or things like that. Well, the good news is if you're at a therapeutic concentration of buprenorphine, that's full agonist, even though it acts more avid, it acts to turn on that receptor to a greater degree, it won't bind it over top of that buprenorphine. That buprenorphine, once it's there, it won't get dislodged because it binds it so avidly. So again, the two really key pharmacologic features of buprenorphine is that it's a partial agonist and therefore has that ceiling effect, particularly thinking about the respiratory depression that we so much fear when it comes to the opioids. But it's a very avid binder, and so it will block the binding for other opioids when they're around. We'll find out here when we talk about some concepts later on. This is a bit of a double-edged sword. It is certainly a feature, but it also has some drawbacks. We'll talk about that in here in a bit. So the history of buprenorphine, it didn't start the way that it is now. Things have changed a lot over the course of the last 50 years. First came to market back in the 1970s. I wasn't alive in the 70s, so I can't speak to this firsthand. But what I'll say is the opioid world was very different in the mid 1970s than it is right now. And reading a couple of reviews, it looks like the hot opioid for pain control at the time was this combination of morphine and salicylates. And people thought, oh God, we have to stop doing this and use something else. And so they looked at a lot of other semi-synthetic opioids. Buprenorphine eventually kind of sifted its way out of that pool of other candidates. And it was initially marketed for pain control. It had nothing to do with opioid use disorder when it originally hit the market. The first way it was marketed is this medication, Temgesic, which came as these 300 microgram ampules or vials that was for parenteral use. It was for injection only. And so very different the way we think about it now. But it didn't take long for researchers and scientists to look at this and be like, hey, this is pretty different than the morphines and the heroines and the oxycodones of the world. Not that they were all around at the time, but it acts pretty differently. Maybe it's got some different therapeutic uses. So it didn't take long for people to look at this partial agonism and this tight binding and say, maybe this could be a candidate for the treatment of patients who are chronically using opioids and want to get away from them. That was actually in 1978 that was first recognized by like this. But as with many things in medicine, it took a long time for those wheels to turn and ultimately for people to recognize and start treating buprenorphine as the OUD treatment that we now think of it as. And sorry, when I say OUD, I'm referring to opioid use disorder. I imagine most of you know that, but just to clarify. So the first major trial that looked at buprenorphine in the setting of the treatment of patients with opioid use disorder, in this trial, it was IV heroin users. But the first trial came out in 1992. And this is one of three major trials that we'll talk about that the FDA really leaned on when it came to the approval of buprenorphine for the treatment of OUD. And what they found is they looked at buprenorphine 8 milligrams daily. We'll find that's a fairly common dose. And they compared it to methadone, either 60 milligrams, also a fairly common dose, or low dose methadone, and said, how long do you stick around on treatment? And what they found over the course of, I don't know, a half a year, quarter of a year, something like that, that there was a significant increase or improvement on treatment retention when it came to buprenorphine versus that low dose methadone. And it was about the same as the standard of care, methadone. We'll talk a little bit about why buprenorphine may be preferable to methadone, but ultimately in this scenario, they're finding, hey, buprenorphine is certainly not worse than methadone when it comes to this outcome. A few years later, 1998, there was Dr. Ling and colleagues, then took this another step further and said, okay, it works on keeping people in treatment, but how much buprenorphine do we need? The first trial had tried 8, but we didn't know. And so they looked at a number of different doses, but their primary outcome was to say 8 milligrams of buprenorphine versus 1 milligram of buprenorphine. How long do people stick around on treatment? As secondary outcomes, they also tossed 4 milligrams daily, also tossed 16 milligrams daily. But they, again, were really looking at 8 versus 1. And when I glance at this chart, I love this Kaplan-Meier curve because it just is just giving you a dose response curve that very much, I think, demonstrates the effectiveness of this medication for treating the disease at hand, in this case, opioid use disorder. This, again, to orient you to the graph, it's the same thing as the prior one. It's looking at retention in treatment prior to relapse of their full agonist. And what they see is that 8 does a lot better than 1, but you can also see it step right on up. 1 is the worst, 4 is a little better, 8's maybe about the same, if not a little better than that 4, and 16's probably the best. So a nice dose response curve. And this is where we, at least one of the main studies that helped us to land on 8 milligrams as being a workhorse dose for treating patients with opioid use disorder. Now, in the late 1990s, people were starting to think, hey, this has actually got some legs. But I'm a little bit worried about if we give buprenorphine from just your clinic and not in these outpatient treatment programs, these OTPs, and that's the setting where you get methadone. To orient folks, if you're not familiar with this, if you get methadone for the treatment of opioid use disorder, you got to go in every day. You go into your OTP, you get your single dose at a time, but you're not getting a 30-day, 60-day, 90-day supply. You're getting your one-time dose and you got to come back every day. That's onerous. It's certainly not patient-centered. But they did it because there was concern about drug diversion. And so buprenorphine has those pharmacologic parameters, that partial agonism that made people optimistic that it wouldn't be as much of a threat for drug diversion, for misuse, things like that. But people still, that threat was still kind of in people's minds. And so they said, how about this? Let's co-formulate buprenorphine with naloxone. Now, a couple of other pharmacologic features or parameters about buprenorphine. It undergoes a high first pass metabolism. And what that means is if I just take a pill of it and swallow it down, my liver will receive it first. My liver will metabolize the heck out of it into an inactive metabolite. And then I won't get any of my buprenorphine. So we don't swallow pills of buprenorphine. It's all sublingual, meaning under the tongue or in the cheek. And we'll talk about the formulations here in a moment. But those are the main ways that oral buprenorphine goes. And they said, well, hey, naloxone actually isn't absorbed when you do that. And so if I give you some of this buprenorphine co-formulated with naloxone, you're not going to get the naloxone. That's the antagonist. That's the blocker. And so if you get the naloxone absorbed into your blood, you would precipitate severe withdrawals. But that doesn't seem to happen when I take it orally. But a patient can't go and then take this combo formulation and then melt it down or break it down and inject it into their veins or smoke it or things like that. Because in that scenario, the naloxone is absorbed. You will get that naloxone and you will precipitate withdrawals. And so it was done as this prevention method to get people to avoid diverting the medication. And so this last study comes from 2003 in the New England Journal of Medicine and looks at, hey, when we co-formulate it, is it still okay? And ultimately found that it is. Opioid cravings have the same reduction as when you have buprenorphine alone versus the combo product, that buprenorphine naloxone. Retention and treatment about the same. The clinician and the patient's impressions of how they're doing is about the same. So it says, all right, well, we're not losing anything therapeutically when we throw the naloxone in. It makes all of us feel better that nobody's going to divert it. And so why don't we just go ahead and co-formulate it? And that's why you're going to see that as such a common formulation for buprenorphine. We know it's as effective, doesn't precipitate withdrawals, but makes those higher ups a little bit more comfortable with the process of starting these medications, not from the OTP. So let's fast forward to the future to now. How can you get buprenorphine now? Well, it comes in a number of different flavors. You can either get short-acting oral buprenorphine. We talked about that a little bit. And we'll break that down a little bit more here in a second. And then there's also long-acting parenteral, meaning not by mouth formulations. Oral can be a tablet or a film. Either way, you're not swallowing this thing. It's just going under the tongue, but it also can go in your cheek. There's a cheek formulation. There's an under the tongue formulation. There's films, there's tablets, you name it. There's all sorts of different flavors. And then the other thing is you have to think about, are they with or without naloxone? Ultimately, there's no data that at least I'm aware of that says that any of these combinations, tablet, film, with, without, are more effective, more safe, more harmful, whatever, than the others. But they're all out there and available to you. And a lot of it's just going to depend on what's on formulary for you at your facility. The only plug I'll put out there, this is anecdotal, I don't know of data to support this claim, is that it seems as though for folks who are dealing with really dry mouths, that the tablets don't break down quite as well. They get a little gummy when you put it under the tongue. And so you have to have them like swish and spit a little water before you do it, versus the films maybe break down a little bit better and are maybe a little bit more available in folks who are dealing with some dry mouth and things like that. So maybe an offhand benefit, but nothing I'm aware of data-wise to substantiate that. The flip of this is the long-acting parenterals. So there's the patch. To my knowledge, this is only FDA approved for the treatment of chronic pain, not for the use of opioid, not for the treatment, of opioid use disorder. But there is a caveat to that a lot of people still use this patch for the treatment of opioid use disorder. And they're doing it in pretty cool and novel ways, but beyond the scope of this talk, but FDA approval wise only for pain. And then there's some injectable forms as well. They're either given weekly, more commonly though, monthly. And either is this implantable device, it's like these little matchsticks you have to shove up under the skin. Obvious limitations of that is like not any Joe on the street can go ahead and give you an implantable device. I don't know how to give an implantable device. You don't want me giving your implantable device of buprenorphine. Something's gone wrong if that happens. But the sub-Q injections are probably a little bit more straightforward. You just put a little bit of buprenorphine under the skin. It stays around for 30 days. And the at least theoretical benefits of these long-acting parenteral formulations, there's a few, but the main one is that you're going to have improved adherence. You don't have to take it every 30 days because it's with you no matter what for 30 days. So that's the main reason that those exist and why people are more excited about some of those. So let's talk about impact. Buprenorphine, we've got a sense that it's safe. We've seen some of that prior data, but what do we know now? Well, so I shamelessly stole this chart that Dr. Andrew Herring put this together, and it's data that's pulled from this website called the NNT. It's like the nnt.org or something like that. And it looks at the number of patients that you need to treat in order for your intervention to cause an outcome. And so if you look at this list, at least the top four, you're like, well, those are all pretty darn standard when it comes to medicine. I mean, general medicine, it's aspirin in a heart attack. Yeah, we do that. It's warfarin in somebody who has atrial fibrillation because we don't want them to have a stroke. Well, we do that too. Steroids for somebody who has a COPD flare, that helps. Defibrillation, shocking somebody whose heart is not beating. Yeah, we do that a lot. And all of those things are standard of care. But then you see what rises straight to the top of this. It's buprenorphine for the treatment of opioid use disorder, and it takes only 2 patients to retain in treatment. So not bad. But maybe you're looking at this. Certainly, there are some people who look at this and say, like, look, retention and treatment is not the same as saving a life. It's not the same as preventing a stroke. That's not the outcome that I care about. Well, let's talk about outcomes that we definitely care about. When we look across the board, for patients who have opioid use disorder, when we think about complications like infectious complications, abscesses, infections in the heart called endocarditis, when we think of hepatitis C or HIV, when we think about run-ins with the law and ultimately landing in jail, things like that, buprenorphine and or methadone, I'm not excluding methadone from that comment at all, but those two medications for the treatment of opioid use disorder reduce all of those negative outcomes. And I think most people would care about those things for the people who are using IV drugs and using opioids. But mortality is always going to be the holy grail. And so this is a study from 2018, cohort study, looking at 17,000 patients over a couple year period of time who had had a non-fatal opioid overdose. And it follows them out for a year afterwards and says, okay, how often are people dying? And then let's break it down by whether or not you got treatment. And so the top line with no diamonds or triangles or squares or anything like that, that's the folks who got no treatment at all. They die, and we have a number of different studies that look at this, but they die about 5.5% of the time, especially when they come out to the emergency department for a non-fatal overdose. About 5.5% of them will die in the next 12 months. Like, that's massive numbers. That's devastating numbers. But for the patients who are exposed to buprenorphine, methadone, I'm going to pull those out specifically. For the patients who are exposed to those, that comes down by about 60%. It's still a decent amount. It's still a scary period of time for them, but that's a massive reduction. And this is a big deal of an outcome. This is mortality we're talking about. So really positive outcomes, really positive impact on this high-risk population, especially after they've had something like a non-fatal overdose. And so major changes that we've seen. I noticed in the chat before I started this, that somebody asked about naltrexone, injectable naltrexone, Vivitrol, and why people are kind of pushing buprenorphine or methadone. And if it's okay, I'm just going to kind of make a quick aside because it's on my mind. And this slide is the first thing that I thought of. Now, to spend just a touch more time on this study, if you look at patients who receive naltrexone, their mortality is about the same as buprenorphine, as if they've received buprenorphine or methadone. But that's only true in the month in which they received the treatment. If you then include the months after they received the treatment, let's say they just stopped taking it for a month, and that can happen with any of these medications. But if you include the month in which patients who are on IV naltrexone after they've stopped taking it, their mortality benefit goes completely away. And so the concern with naltrexone, at least in my mind, is A, it's really hard to induce someone on naltrexone. They have to be truly, truly off of their opioid, because you give them just a whiff of a full antagonist of that opioid receptor, you're going to make them withdraw, full stop. The other problem is it's effective while they're on it. And if they're on it 100%, perfect. That sounds great. I would take that every day of the week. That's great. And I would never push buprenorphine over that. That's a great outcome. It's just not that easy to achieve that because it's hard to start them on it. It's not going to treat their craving at all because it's an antagonist. And then if they stop taking it, they are actually at higher risk for opioid overdose death than somebody who's on nothing at all. And so I look at that kind of conglomerate of information. I think I'm probably not going to give a bunch of naltrexone. So I'm certainly happy to kind of talk that one out a little bit more. But that's my hot take on why I would pick buprenorphine or honestly methadone. I'm not an anti-methadone guy. I would pick either of those over naltrexone. So those are the good things. Buprenorphine saves lives. It prevents infectious things. You run into the police less often. Those are all good things. But as anybody on this call is well aware, we still have a bit of an opioid crisis going on. And it's multifactorial why that is, but at least part of it has to do with this just yawning treatment gap. This is a really cool study done just last year that looks at a 10-year period of time, looking at from 2010 to 2019, all the patients who had opioid use disorder, and then all the patients who were receiving any treatment for opioid use disorder. So that includes naltrexone, methadone, buprenorphine. And I'm not going to split them out here. But when you look at least in 2019, there was about 7.5 million people who were eligible for the diagnosis of opioid use disorder and therefore eligible for treatment with these medications. And about 15% of that group was actually in treatment. So 85% of that group is not being treated. Now that gap has narrowed a little bit in 10 years. That's attributable primarily to the rise of buprenorphine. Methadone stayed about flat. Naltrexone's maybe gone up just a bit, but buprenorphine's really the one that's driving that change or that closure of that gap. But that gap remains absolutely gigantic. So that's a problem. What can we do? The first thing, in my opinion, that we can do is to get out of our own way. And what I mean when I say that is we nationally have legislation that makes it harder to deliver medications for the treatment of opioid use disorder to patients who need it. Now, I was trained, in the mid-teens for emergency medicine, and I was always taught to hate the Data Act of 2000. And the reason I was taught to hate the Data Act of 2000 is because it implemented this X waiver requirement, which in hindsight feels very stupid, but it was actually a major step forward at the time. And so to take a quick step back to the 1990s, remember, the only thing we had to treat opioid use disorder was methadone. Great, it works. The problem, obviously, we've talked about is it can only be delivered from these OTPs, these outpatient treatment programs. You have to go in every day. It's incredibly onerous. And talk about non-patient centered and a gigantic treatment gap. Methadone's a poster child for that. Well, the Data Act says, all right, well, that's not great. Let's start thinking about buprenorphine. And when we think about buprenorphine, let's start thinking about it from the office. And so that's a huge step forward. And in my mind, and admittedly, I did not give it very much credit, but that is a huge step forward that we took in 2000. The problem is we still left a bunch of red tape in the way. And when I mean red tape, I mean the main things are prescribers could only administer 30 patients at a time. You could only have 30 active patients at a time. And you had to get this X waiver. And the X waiver is like a colloquial name for this data, essentially an addendum to your DEA license to say, yep, I can deliver a bunch of fentanyl and oxycodone and hydrocodone and all the other codones. But I've got to do a special training to say that I can give buprenorphine for the treatment of opioid use disorder, which is unquestionably ironic because it's the safest of that bunch, but whatever. And so that lingered on for 20 years where you had to get this X waiver, and it was repeatedly cited as one of the main barriers to docs delivering buprenorphine. There's a number of other barriers as well, but that Data Act, that X waiver stood in the way for a lot of docs. It's not that huge of a challenge, but honestly, anytime you put even a tiny step in the way of a doctor, you're going to find a way to go around it or just backslide. So a couple of things did happen in the intervening 20 years. In 2018, the Congress and the Trump administration pushed through the Support Act, passed with not unanimous, but with bipartisan support, where it didn't get rid of that X waiver, but it did massively improve the pool of prescribers who could deliver buprenorphine. And what I mean when I say that is that NPs and PAs all of a sudden had permanent ability to get an X waiver. Certain other nurse practitioners or nurse specialists could then deliver buprenorphine. They were also eligible. It increased the number of patients that a prescriber could give buprenorphine to at a time. So a lot of things helped, but didn't get rid of that X waiver. But thank goodness last year, finally, this MAT Act, the Mainstreaming Addiction Treatment Act, did the job. X waiver's gone. If you have a DEA license, you can give buprenorphine. You had to do like a little 4-hour seminar or something like that to say that, yes, I understand what I'm doing. But that X waiver is gone. So a lot of big changes that are getting rid of some of the red tape. I think it's to be seen still what the impact on this on closing that treatment gap are, but steps in the right direction. The other thing that I want to highlight is thinking about where we are giving buprenorphine. So again, methadone and the OTPs, that's not great. Buprenorphine just in clinics, that's better. But you think about patients who use opioids, who suffer from opioid use disorder. There's a lot of other comorbid conditions that come along with that, and a lot of other socioeconomic barriers that are likely going to make it difficult to routinely get into my doc every 30 days or something like that. I personally have a hard time getting to my doctor every 6 months. And so you add in a lot of other socioeconomic or medical barriers, that's a tall task. So in 2015, this group in Yale led by Gail D'Onofrio, and who's become really the guru and kind of the patron saint for a lot of this movement, they said, all right, well, if the patients aren't coming to their clinics, let's meet them where they are, because they do come to the emergency department. Patients who deal with opioid use disorder or who are injecting or dealing with these complications, maybe they have an abscess in their arm, or maybe they have a bloodstream infection, or, I mean, you name it, maybe they come in after an overdose or with opioid withdrawal. If we find them there, even though that wasn't their primary source of access, what if we just start them on buprenorphine right there? And so what they did is they did a randomized control trial. They gave buprenorphine versus this simple intervention plus linkage to care versus just linkage to care. And what I mean when I say linkage to care is that, they don't just discharge you straight from the ER and say, best of luck. They give you a follow-up appointment with what they call a bridge clinic, who can then continue to prescribe buprenorphine, after your emergency visit is done. And what they found is that about a month after discharge, 78% of those who got buprenorphine in the ER, as compared to 37% who did not, were still in treatment. That's massive. And this is a brand new locale to be able to deliver this, what we now know is an evidence-based and life-saving therapy. So a huge step in the right direction. And you look at you PubMed search ED-based buprenorphine now, you're going to get 1,000 articles because there's a ton of programs that are out there. There's a ton of novel ways of delivering buprenorphine, a really cool and exciting area of research, but a really, I think, important way of trying to close down that treatment gap. This is step one. There's a lot of steps that have been taken beyond this. But I think a lot of momentum toward meeting, again, the verbiage, the saying, I think, as it were, is that we're meeting patients where they are. If they're not going to be in the clinic, let's meet them in the ER and let's start them there because they're going to do better than if we do nothing at all. So that's the good news. Precipitated withdrawal is not necessarily the bad news, but it's maybe like the bit of the fly in the ointment. So let's talk about the physiology and kind of where we stand with precipitated withdrawal now. So the physiology of precipitated withdrawal, I think, is pretty fascinating. We're going to just run through it and understand kind of what we're all talking about. So going left to right, this panel on the left talks about a patient who is not on opioids. So I've got a bunch of mu opioid receptors hanging out on my cell membranes. They're ready for an opioid, either endogenous, like one of my own personal opioids or something like that, or if I take a dose of oxycodone, waiting for something like that to go bind it. And if it binds it, it'll turn it on. Great. And if I'm not taking anything, I'm not in withdrawal. Also great. But in the middle here, if I'm constantly taking a full agonist, and that refers to the fentanyls and the methadones and the oxycodones and the heroines of the world, if I'm chronically taking all of those, your body eventually is going to be like, whoa, guy, let's slow your roll. Let's decrease the amount of these receptors that are available because you're constantly bludgeoning these things. And so we'll find kind of a new homeostasis where, yeah, you have a lot of these agonists, that little gray arrow thing. You'll have a lot of these agonists. You've got the opioids around, but we'll have fewer receptors. And so you're not going to just constantly be really, really opioid toxic or intoxicated. There's two really important clinical outcomes that come in this scenario. The first is tolerance. If you have fewer of those receptors, or they're just not as, if they are in a desensitized state, meaning they can't be turned on. But ultimately, if you have fewer of those receptors available to you, then you need more of that opioid around. And so your dose requirement to either achieve a high or just to keep from feeling like garbage is going to go up. The other is withdrawal. All of a sudden you take out that opioid because I've been abstinent for 2 or 3 days or whatever. Well, all of a sudden my diminished supply of opioid receptors that's floating around is going to be like, hey, I need those things. And so all of a sudden you're going to go into withdrawals. And so that's where that comes from. Buprenorphine fits into this. So let's say we go back to the person who's taken their fentanyl or their heroin or whatever. They've got all of their receptors saturated. They're in their homeostatic state. They're doing okay. But then some good doc comes in and says, hey, I want to start you on buprenorphine because I've heard it's good. But they don't wait for the patient to start withdrawing. And so all of those full agonists are occupying those receptors. But remember those two pharmacologic concepts of buprenorphine that were so key that make it so successful for the treatment of opioid use disorder. Well, if I give that really strongly binding buprenorphine, it's going to knock off all of that fentanyl or heroin because it binds stronger. It's going to displace all of it. That's not great. And the second is, yeah, it's going to turn it on a little bit, but it's not going to turn it on all the way. It's a partial agonist. And so it's trying to turn on this limited supply of opioid receptors, but it's not doing it nearly as effectively as that fentanyl or that heroin was. And so for a person who has kind of this change in their physiology from chronic opioid use, they're actively using opioids. They're currently opioid intoxicators. They're recently used. All of a sudden, you give them buprenorphine. You're going to displace all of that other opioid. You're going to give them buprenorphine, but that's not going to meet their need. And that results in what we call precipitated withdrawal, meaning I gave you a medication that put you into withdrawal. And it's one of the major fears for when we start patients on buprenorphine. To avoid this, what we'll do clinically is we'll wait till the patient's in withdrawal. We have some validated scales. The most common one is this COWS score, the clinical opioid withdrawal scale or score. I forget what the S is, but it measures a bunch of symptoms for your opioid withdrawal. It's yawning and nausea, vomiting and diarrhea, and you got big pupils and your skin's sweaty and stuff like that. You measure all of those things. And if you say, if I've got a score of 8 or above, I think you're in enough withdrawal that I can go ahead and safely give you buprenorphine and I'm not going to precipitate withdrawal. That has been, that paradigm works generally speaking, but has been complicated in the last couple of years by the rise of fentanyl. This is like one of the more jaw-dropping charts or papers I've looked at in a while. It's just from last year, and it's a look at the amount of illegally seized fentanyl in the United States from the years 2018 to 2021. And they break it up by quarter of each year. So it's 12 or 16 quarters. And what they find is from Q1 of 2018 to Q4 of 2021, there is a 4,800% increase in the number of pills of fentanyl that has been seized in illegal drug seizures. And I think this goes along with what, again, probably everybody on this call knows, that there is this massive proliferation in the availability of fentanyl in our illegal or illicit drug supply in the United States. Clinically, we know this matters. I mean, this is, again, like, this is a duh chart right here. So all of the other opioids and other kind of co-ingestion substances of abuse that are resulting in overdose deaths, those have kind of been tinkering along for a long time. Methamphetamine's causing more and more more and more deaths recently. But the one that really jumps off the page is that gray line. That gray line's fentanyl. Fentanyl is causing vastly more death than really any of the other opioids combined. It's what's driving the continuation and proliferation of the opioid epidemic. And so it's clearly a pressing need with the fentanyl around, that we have more patients with access to medication for opioid use disorder. But the problem is, not only is fentanyl around a lot more often, but it poses some kind of novel problems for when we think about starting somebody on buprenorphine, when we think about the concept of precipitated withdrawal. And the reason being, fentanyl sticks around for a real long time. Now, if I'm in the ER, somebody's got a broken leg, I will give them a dose of fentanyl without blinking, because it hurts a lot. Fentanyl is very effective for rapid pain control. It's fast on, it's fast off, and that's a perfect picture for somebody who I need to do a quick procedure on. But that's for a fentanyl or an opioid naive individual. When you look at folks who take opioids, or fentanyl specifically, every day, well, fentanyl has some biochemical properties that make it a bit more complicated. The main one is that it's very lipophilic. It likes to sit in the fat in our bodies. The fat can mean just like the fat in my abdomen, because I live in Wisconsin, or the fat can be some of those tissues that are in your central nervous system. And so they can kind of go and just depot into your brain, into your CNS. That's real problematic. And this is another really cool study that looks at daily fentanyl users who would come in for inpatient addiction treatment for rehab. They're not using opioids over the course of this study period of time. And the researchers look at what is your fentanyl concentration in your urine day by day as you kind of linger with us in the treatment. What they found is that the mean number of days until fentanyl was gone, meaning you had a negative fentanyl urine drug screen, was about a week. That's pretty long. The inactive metabolite took about 2 weeks. But the craziest is, for the longest patient, this is only 12 patients. There's probably crazier cases out there, but their longest fentanyl positivity case was 19 days, 3 weeks, where fentanyl was still in this patient's urine. So ultimately what we see is, yeah, it's a short-acting medication, but when you're chronically on it, boy, it really builds up in the body, and it's going to stick around for a long time. And if we revisit that model of precipitated withdrawal, and we think about an opioid that's around for this long of a time, we think, boy, that fentanyl is probably going to be bathing that mu opioid receptor and be bound to that mu opioid receptor for a lot longer than the 12 or 24 hours that we typically think about before we start buprenorphine. And it could be days until somebody has been done with their fentanyl before they can start on bupe. This is corroborated by patient experience. So another really cool study, and I would very highly recommend tracking this one down. I think it is a really compelling read. It's from Dayton, Ohio in 2019. It's entitled, I think very, very appropriately, Everything Is Not Right Anymore. And it looks at patients' experience with starting buprenorphine prior to and during the age of illicit fentanyl. And it's a qualitative study. It's a lot of patient interviews. And you get these really just, I think, profound quotes where they say, yep, it sends me into withdrawal, precipitated withdrawal every time I try to get off fentanyl. Then I've got these doctors trying to tell me, hey, that's not real. And it's like, go ask the people who are buying it off the streets. It's real. I waited for 80 hours and I was in a detox. And after 80 hours, they gave me Suboxone, which is a combination product of buprenorphine and naloxone. And it still put me into precipitated withdrawal. So that biochemical model that we discussed, that came after we started listening to these patients. They're the ones who kind of put the medical community onto the idea that this is a problem. And we'd have explained it subsequently. So something that the patients are experiencing biochemically, we can explain, and it's a problem that we need to find some novel strategies for. The good news is there's smart people in the world and they're doing smart things and they're thinking about smart solutions. There's two ways to go about trying to circumvent this problem in the age of fentanyl. The first is with what we call microdosing. So standard, quote unquote, standard dosing of buprenorphine is usually about 4 or 8 milligrams on your first dose. Depends on where you are. Microdosing takes the approach of, let's give you this itty bitty, teeny weeny dose of buprenorphine so that if you still have that full agonist around, the fentanyl or the oxycodone or the methadone or whatever it is, if that's still around, we're going to give you such a tiny amount, it's not going to displace enough of that full agonist that you're going to feel withdrawals. And it's really interesting. The first time that this microdosing strategy came around was well before fentanyl. This is actually back in 2010 in either Germany or Switzerland. And it was used on patients who were on heroin, and then subsequently used on patients who were on methadone and wanted to switch over to buprenorphine. And the way they would do it in those studies is they would say, you can keep using your heroin or your oxycodone or your methadone, and we'll just bit by bit build up the amount of buprenorphine that you're taking, and gradually will wean off of your full agonist. And so patients don't have to go through that period of withdrawal before they get on buprenorphine. Kind of a cool strategy and elegant approach to getting these patients started. Well, this has been applied to the age of fentanyl as well. This is a study that came out of Vancouver just, I want to say 2 years ago. That might be wrong. But came out of Vancouver recently from an emergency department that said, okay, well, we know that fentanyl is a problem, or we think it is at least, when we're trying to initiate patients on standard dosing of buprenorphine. What if we're going to start them on these microdoses, but do it from the emergency department? And so what they did, they started with teeny doses. Like if you look across the board, they started actually with a fairly standard dose. I read that wrong. But kind of across the board, about 0.5 milligrams of buprenorphine is a pretty normal start. You'll see as low as 0.2, as high as 1 milligram, but 0.5 is kind of right smack in the middle. So they started with 0.5 and then gradually over the course of 6 days escalated that buprenorphine. They had no cases of precipitated withdrawal. Their adherence at 30 days was not great. It was around 20%, but that wasn't actually that different from the non-microdosed cohort. So did not show any inferiority, at least in that kind of proof of concept trial. I think this has a lot of interesting concept to it. I think it's a really interesting concept. What I'll say is the data is certainly there for kind of its use in the office setting. But when you talk about initiating a protocol that can take between 3 and 14 days from somewhere like an emergency department, which I'm biased to because that's where I work, that's pretty hard. That's a lot of moving parts. That's a lot to ask of a patient, especially if they're, under domiciled or if they have other kind of barriers to access and barriers to care. I think this is a pretty challenging thing, but it's certainly not stopping people from trying. It'll be really exciting to see how this works out for folks. The other side of that coin is macrodosing. So I think in my head, microdosing makes a lot of sense. I'm going to give a really small amount. I'm not going to precipitate withdrawals because I'm just going to be such a wuss about it that I'm not going to cause any problems. But macrodosing is like, I'm just going to go head first, straight into the pit and see what happens. But there is a little bit more biochemical rationale and reason why it may be effective. So I think this one takes a little bit more explaining as to why this would work, but this diagram that I tracked down from a presentation, I think is very helpful. So let's say in this picture, all of the plates are opioid receptors. On the left, where you've got muffins, that's your full agonist. That's your fentanyl, your heroin, whatever. You all of a sudden give them buprenorphine, but you give it in a low to moderate dose at 4 to 8 milligrams. Well, all you're going to do is knock off that fentanyl or whatever, and you're going to leave the rest of those opioid receptors unbound. And so I've gone from full agonism to partial agonism, and now I feel like garbage. Well, that's precipitated withdrawal. But let's say instead of being a wuss, we just go head first and we give you a full 16 or 32 milligrams. I don't know of anybody who gives 32 milligrams off the bat, but 16 or 20 milligrams of buprenorphine. I'm going to try to saturate all of those mu opioid receptors right off the bat. And so, yes, I will replace my full agonist with buprenorphine, and that's problematic. But I will have given so much of this partial agonist, and I will have bound so many of these otherwise unoccupied mu opioid receptors, I'll actually wind up with some symptom relief, and I won't precipitate withdrawal, and patients will feel a lot better. Well, the obvious benefit to that is it's one shot and you're done. You give them a gigantic slug of buprenorphine. You fill all those receptors. They're induced. They're started. All they need at that point is a linkage to care. They feel better quickly. They get linkage to care. The problem is the lack of data. There is not much out there that describes this. This is a poster from the American Society of Addiction Medicine conference back in 2020 that came out of, I believe, Rutgers, but looked at a case series of folks that have been treated in this way. And you're not going to find a lot more robust data from macrodosing approach than something like this. So I apologize for the poor quality image, but this is the best I could track down. But it's a group of 15 patients who receive macrodosing. If you look across kind of that graph at the bottom or the chart at the bottom, they ranged it from 16 to 20 milligrams for that first dose. So they gave them that large dose of buprenorphine. 10 of them were successfully induced, meaning they felt A-okay after that. 5 of them needed some additional symptoms, but nobody, I think really importantly, nobody had precipitated withdrawal, and the bulk of the rest of them were able to be treated with either additional buprenorphine or some other adjunct agents. And so it didn't seem to result in adverse outcomes. When we're thinking about the world of fentanyl and all the complications in regards to precipitated withdrawal, we're thinking about kind of novel strategies. And again, I'm a biased guy because I'm an ER-based guy. And so when I think about my approach going forward, this is the one that it certainly doesn't have the data for me to kind of stand on and comfortably say this is the way to go forward. But it's the one that I'm most interested in. I'll definitely say that because it fits the needs of that setting. And I think if you can get rapid resolution to those symptoms, that's pretty compelling. But more to come for sure. So as a summary slide for the precipitated withdrawal and kind of where fentanyl sits in, again, keep in mind there's three strategies. I can microdose here at the far the far left end of this bell curve. I can microdose where I get no displacement of my full agonist, and the patient winds up being okay. The obvious downsides of that is that it takes a long time to get this up and running, is a lot more intensive as far as the resources and needs of a patient to get started in this way. But the good news is you basically have no risk of precipitating withdrawal. If you're given 0.2 or 0.5 milligrams of buprenorphine, that patient will not precipitate withdrawals. I can say with reasonable confidence. The far end of the spectrum is that macrodosing approach, where yes, I'll displace, but I'll also saturate those mu opioid receptors. And I'll also, theoretically at least, wind up with a happy patient. So that's where I think you're going to find a lot of patients living going forward. I don't think it's certainly not sorted out which is the superior outcome. I think we're finding safety data to say that at least the microdosing is safe, macrodosing to be determined, but I think they both offer some promise in different ways. But to live in the middle with quote unquote standard dosing, which is that 4 or 8 milligrams of sublingual buprenorphine, well, that's when you're going to displace but not saturate, and you're going to wind up with a Mr. Yuck on your hands. And so I think if you look at protocols across the country, my bet, I can say the institution I work at, we still use a standard dosing approach. I don't think we've run into significant problems yet, but I think as the literature base improves and kind of builds up when you think about buprenorphine precipitated withdrawals, especially in this era of fentanyl, I think there's going to be a lot of push to the margins, either to that microdosing or macrodosing strategy. A lot more still to learn. But I think that's really one of the main points of conversation when it comes to buprenorphine for the treatment of OUD. These are my references. And with that, I will conclude and happy to take any questions.
So it looks like there were a few questions here. You answered one already from Mary Margaret Malone. She asks, is there any research on how to assess whether Suboxone or methadone is a better fit with individuals?
I think the answer to that is probably. I will say anecdotally, I have started to encounter a number of patients who have some fear about buprenorphine, and I'll stick with the generics, but who have some fear about buprenorphine with the concern for precipitated withdrawals, which I have no argument against. I think it's valid. So I think there's patient populations who are fearful of what can happen with starting buprenorphine. But also, I think when you have that conversation with the patient, I think it's important to have that full and kind of holistic conversation with them to say, this is what methadone looks like. Yes, it's a full agonist. No, you will not precipitate withdrawals with methadone. But with methadone, you got to come in every day. With buprenorphine and these varying formulations, some of them being subcutaneous, some of them with even the oral formulations, you can take home prescriptions of them. They're far more patient-centered, at least in my opinion, far more patient-centered and I think cohesive with living a normal life. And so I think when I have that conversation with patients, I talk about, yeah, that's a fair comment. You can talk about kind of strategies to decrease that risk of buprenorphine precipitating withdrawals, but also having a very kind of holistic conversation about what methadone looks like. And I think it's a bit more challenging to get onto and to stay onto. Some patients anecdotally will do better on one versus the other. I certainly talked to a number of patients who have like I said, no interest in Suboxone or buprenorphine. They prefer methadone. If that works for them, that's great. That's the way it should work. I think it's going to be interesting, especially in the era of fentanyl, to see if we are starting to see a decreased efficacy of buprenorphine, if it's just too potent of an agonist, and if it's just built up in their fat in too great of degree, where that partial agonism is no longer effective. I think that's going to be an interesting thing to look into over the next 10 years. But I actually answer your question. No, I'm not familiar with any research that would say that there's a bona fide or validated strategy to say which one works better for the others. But I think it's just to take in that holistic picture of the pros and cons of each. Buprenorphine is a partial agonist, and so you risk precipitating withdrawals, and sometimes their cravings are not adequately sated by buprenorphine. Methadone will take care of those things, but methadone comes with its own complications or difficulties, not complications, but difficulties as well.
Thank you. Then Sabrina Donovan asks, is it still suggested that the buprenorphine treatment be about a year long?
I will plead the fifth. I'm not familiar with that suggestion in the first place, but I will absolutely say I've taken care of a lot of patients who were on it for a much longer period of time. I don't have a reason why patients should be stopped after a year. Again, same kind of stigma that lives out there. You'll have patients who say, I don't want to swap my heroin for buprenorphine. I don't want to just switch from one opioid to another. What's the point of that? But when you look at, again, all of those important outcomes that we kind of talked through, there's no reason these patients can't be in on it lifelong. And I've absolutely taken care of patients who have been on these medications for a decade, and they do fine. And so I'd say there's no hard and fast reason why a patient should be stopped at a year. I think physiologically that doesn't necessarily add up. And I'm not at least familiar with any recommendations that should be the case. I think patients can be on it as long as they need it. And then there are some strategies for how to wean down the buprenorphine on the back end of things, because not all patients want to be on a medication for the rest of their lives. I think that makes a lot of sense. And so there are strategies for how to wean down the buprenorphine, because you can withdraw from buprenorphine as well. Yes, it's only a partial agonist, but it's agonizing that opioid receptor. So there's strategies for how to come down on that as well for when you're on the back end of things. If somebody's in a stable part of their life and they want to come off of it, then great, by all means. And there's ways to go about that as well. But I don't think there's a hard and fast rule for how long to stay on it. But again, I plead the fifth because I've not heard of that recommendation specifically.
Okay. And then again from Mary Margaret Malone, are there any data-based reasons based on something other than stigma for why methadone is so regulated and legislated to be so much less patient-friendly than Suboxone?
Yeah, I mean, a lot of it's stigma. You're definitely right. And so I think it's hard. It's a hard platform to stand on to say that we should be sending patients out of a clinic with a 30-day supply of I mean, there's reasons to send them out on long durations of supplies for any opioid. And so methadone's used for chronic pain and doesn't necessarily need to be regulated the same way. And so there's roles for it, but I think stigma probably sits at the top of those reasons why it is regulated so differently than buprenorphine. But also, I mean, in fairness, buprenorphine's a lot safer. It's not a full agonist. It has a much lower risk of diversion. Those are all evidence-based comments. And so I'd say, yes, there's a reason why methadone shouldn't necessarily be regulated the exact same way as buprenorphine. I think that's a fair comment. But I'd also say that the way that we still legislate methadone is probably a bit of a throwback and probably could use some updating, because I think the access is limited in part, at least because we just haven't loosened the reins for how methadone is administered.
Super. And I think we have one more here. Have you seen or used the rapid initiation using SL Bupe 4 milligram followed by injectable Bupe?
I have not. I know there are a few studies that look at this. I don't even think have injectable buprenorphine at my facility, so we live in the dark ages when it comes to all of this. No, so I haven't, but there's a number of studies that look at how to rapidly induce somebody on a large dose. And you can honestly look even at the macrodosing protocols in these experiences and say, you don't even need to get that test dose. If anything, that test dose is the most dangerous part of that protocol. But the group out in Oakland in Highlands, I believe, with Dr. Herring leading the way, looked at a kind of rapid or high dose buprenorphine initiation protocol in the emergency department. It wasn't using injectable as the second round, but it started with a test dose of either 4 or 8 milligrams, and then they gave up to 32 milligrams afterwards to try to saturate those receptors and get patients feeling better. I still look at that and I say, boy, the scariest part of that is the 4 milligrams, not the big dose that comes after it. And I believe there are studies that are looking at all sorts of other ways to go about this. And so I think there are strategies that look at the the patch, where you apply the patch, you get a very slow leak of buprenorphine into your blood over time. And it basically mimics the microdosing strategy, where just gradually you're going to get up to more therapeutic dosing. And then patients can continue to metabolize or clear their fentanyl during that period of time, or kind of transition off of other longer acting opioids. And so I think there's a lot of other parenteral ways of going about this. Certainly people who utilize the sub-Q injectables, people who utilize those patches. And so a lot of really novel and refreshing and kind of cool takes on this. I'm too much of I live in the dark ages too much to say what it's like in the flesh, but a lot of other ways to go about this. It doesn't just rely on kind of those standard dosing protocols.
And then Ingrid asks, any suggestions about SC buprenorphine issues, pros, cons?
So sub-Q Bupe, there are a number of different formulations of those. There are the implantable devices, and then there are the injectables. There's burgeoning amounts of pharmacokinetic data, not burgeoning, there's a decent amount of pharmacokinetic data out there to look at these devices and these strategies. And it varies depending on the way you go about it. So the implanted device will get to really low concentrations of buprenorphine. And so I assume you're talking mostly about the injections, the sub-Q injections, less the implantables, but a brief comment about those is that you're going to get really low concentrations of buprenorphine, so maybe better suited for low levels of chronic pain or for somebody who doesn't have as severe an opioid use disorder, but a little different than the kinetics that you're going to see with the the sublingual. As far as the subcutaneous injections go, again, I don't administer them personally. I've never done it. I'd be really interested to do it because I think it's an exciting prospect. Pros, I think, are fairly obvious. It's with all of these, depot medications. You can include that with folks with poorly controlled, schizophrenia. We give them long-acting injectable antipsychotics to improve adherence. So the same thing applies. It's all about improvement of adherence. Anytime you don't have to take a pill every single day, you can get a shot once a month. It's a lot easier. It's a lot lower of a bar to try to clear. So your adherence is potentially going to improve. What I'll say is the primary fear about this is that if you give somebody a gigantic slug of sub-Q buprenorphine and you achieve pretty reasonable concentrations early on, well, if you precipitate withdrawals, there's no going back. And so I think that's where it comes from. That prior question comes from with that test dose. And so that's a way that people will often do this. Whether or not that's necessary, whether or not it's helpful, whether or not it's potentially even harmful, I don't know. But I'd say the concern about giving the sub-Q injection, at least for the person who is using fentanyl chronically or is not very far from their last dose, is you get fearful of precipitating withdrawals and then having no recourse. It's longer acting. It's going to stick around for a long time. With the sublingual dosing, it's gone quick. Well, not quick. It's gone quicker. We'll put it that way. And so you can get on top of those withdrawal symptoms in a more rapid fashion. So that's I think the 10,000 foot view is that you're going to get better adherence, but maybe a concern about how you get them initiated. And also say, broadly speaking, it's not nearly as broadly available. I mean, you talk about Milwaukee, Wisconsin is, we're not in the middle of nowhere. We're maybe not the cutting edge of opioid use disorder research and buprenorphine, but we're also not the middle of nowhere. And I certainly can say with confidence, I can't give that in the emergency department. I imagine some of our addiction medicine clinics can, but you're not going to see that nearly as ubiquitously as the sublingual formulations. So the other benefit, I mean, ultimately at the end of the day, we're trying to close this treatment gap. I'll lean on the sublingual for now because I know it's out there, but I look forward to the sub-Q stuff coming around a little bit broader.
Excellent. That looks like that's about all the questions that we had. If we've had a couple issues with the Q&A and questions showing up, I put my email in the chat. If anybody has a question that didn't get answered, feel free to send me an email with it. And I just want to thank you, Dr. Comstock, for sharing your expertise with us today. We really appreciate your time, so thank you. Also, thanks to our attendees for showing interest in this topic. And finally, the presentations and slide decks will be uploaded to the Washington Poison Center's website, which is wapc.org, soon after the completion of the series. So thank you all so much, and we hope to see you at other sessions today and throughout the next two.
Thanks, everyone.
Right. Thank you.